My talk will be entitled Hypopharynx. So I'd like to thank Alona for giving me the opportunity to talk on this area, and specifically the focus talk on the hypopharynx. Oftentimes, hypopharynx is lumped together with the larynx, and the larynx gets the full billing and the hypopharynx gets very little attention. So I think I appreciate the opportunity to really get into detail on this very important anatomy. These are my disclosures. And these are the people and organizations I would like to acknowledge, specifically Elsevier, Doug Phillips, Radiology Key, Nancy Fishbein, and Dr. Zhang. The areas that we'll be discussing include the technique, anatomy, neoplasms, infections, and congenital and developmental. I will not be talking about post-treatment, as there's a separate section of ASH&R specifically devoted to post-treatment. And the infections and the congenital lesions that I'll be talking about are specifically related to the hypopharynx. The primary modality that we use to evaluate patients with hypopharyngeal pathology tends to be CT. We all use multi-detector imaging. It's sub-millimeter thick sections. We reconstruct in general about 1.5 millimeters with overlap. We use contrast. I tend to prefer the dual phase technique with approximately 75 cc's of contrast, and we acquire our images with quiet respiration. And I think all of us are doing the nice reconstructions, and this sagittal images that demonstrates a very nice view of the posterior pharyngeal wall. CT is the primary modality for evaluation of patients with hypopharyngeal pathology, but there are other techniques that can be used. I found MR to be used mostly as problem solving, specifically if we're looking for more information if there's cartilage involvement or whether or not there's prevertebral space invasion, and we'll discuss this later. PET-CT is commonly used, and certainly in the practices that I work with, essentially anytime that we have a squamous cell carcinoma, the referring physicians, whether they're ENT surgeons or radiation oncologists, almost default to a PET-CT to look for occult lymph node metastases and distant metastases. And there is some work going on with PET-MR. This tends to be limited to academic institutions that have cancer centers. In general, it's not being used primarily. There is some nice work that's coming out of China regarding the ability of PET-MR to predict response. And I would refer you to this paper that's impressed by Zhang et al. Talking about some of the future directions with PET-MR. Well, so much about head and neck, and especially the hypopharynx, is anatomy. And what I'm going to do is spend a fair amount of time going over the anatomy of the hypopharynx. I tend to divide the hypopharynx into an external superstructure, the innervation, and then the internal anatomy. So the external superstructure is formed superiorly by the hyoid bone. Inferiorly, it's formed by the inferior border of the cricoid cartilage, and posteriorly, it's formed by the inferior constrictor muscle. Now, the superior pharyngeal constrictor muscle is typically, we're familiar with this because it's primarily involved in the oral pharynx, but the inferior constrictor muscle forms the posterior border of the hypopharynx. The innervation of the hypopharynx primarily arises from two nerves. The motor innervation comes from the vagus nerve, and the sensory innervation comes from the combination of the glossopharyngeal nerve, cranial nerve 9, and the vagus nerve, cranial nerve 10, specifically the internal laryngeal branches. It's specifically important to understand this, especially in patients with otalgia. We think of patients that have otalgia with abnormalities involving the ear, the mastoid ear cells, the tonsils, the nasopharynx, etc. But we always have to remember that the branches of 9 and 10 form the sensory innervation of the hypopharynx. And so therefore, pathology that involves the mucosa of the hypopharynx can be referred to the ear, and you can have otalgia. So always keep that in the back of your mind. The internal anatomy of the hypopharynx is defined as follows. Superiorly, the hypopharynx is defined by this little fold of tissue that goes from the pharynx to the epiglottis. This is the pharyngoepiglottic fold. The pharyngoepiglottic fold defines the entrance into the hypopharynx, which is sometimes referred to as the introitus. The inferior border of the hypopharynx is formed by the cricoid cartilage. The anterior border of the hypopharynx is formed by this wall right here, which is referred to as the common party wall. And this term party wall is essentially used to define a wall that separates two different buildings or two different residencies, etc. So this separate party wall separates two different areas, the hypopharynx from the larynx. The posterior margin of the hypopharynx is formed by the inferior constrictor muscle. The medial wall of the hypopharynx is formed by the aryepiglottic fold. Now, in the larynx, the lateral border is the aryepiglottic fold, but the hypopharynx is the aryepiglottic fold. So again, the aryepiglottic fold, again, has a common border. And the lateral wall of the hypopharynx is formed by the lateral wall of the pharynx. So the hypopharynx has three primary subsites. These are the piriform sinus, the posterior wall, and the post-cricoid region. And we're going to go over in great detail these specific areas. So the piriform sinus is a pear-shaped structure that it starts from the pharyngoepiglottic fold. Inferiorly, this pear gets narrower and narrower and eventually forms into a small little apex, which is referred to as the apex of the piriform sinus. So on the CT scan on the right, this is the most superior aspect of the pharyngoepiglottic fold. We can see the lateral aspect of the piriform sinus here. A little bit more inferiorly, we can see the aryepiglottic fold forming the medial wall of the piriform sinus. And on this non-contrast T1 weighted MR, we can see the high signal, the cricoid cartilage, the arytenoid cartilage, the cricoarytenoid joint. And right at the level of the cricoarytenoid joint is the apex of the piriform sinus, which corresponds with the little narrowing here, the tip of the pear, if you will. The posterior wall of the hypopharynx is formed by the inferior constrictor muscle. So on the left here is a schematic illustration, the diagram of the inferior constrictor muscle. Here's our diagram of the inferior constrictor muscle forming the posterior pharyngeal wall. This is our three-dimensional reconstruction, and on the axial images, here's our posterior pharyngeal wall here. Now, more inferior to it, we can see the tip of the arrow forming the posterior pharyngeal wall. This high signal here forms the lumen, and the posterior pharyngeal wall is typically very, very thin. Now, more inferiorly, there's a transition between the posterior pharyngeal wall and the opening of the esophagus. And this transition is referred to as the esophageal verge, and we'll have much more to say on this later. But the posterior pharyngeal wall eventually transitions into esophageal verge, and the esophageal verge eventually goes into the cervical esophagus. And the inferior border of the posterior pharyngeal wall is this muscle, which is the cricopharyngeus muscle. The post-cricoid area is a very unique area that separates the hypopharynx from the larynx. And as I mentioned before, there's a common wall here that extends from the hypopharynx to the larynx that's referred to as the party wall. This specific area, this post-cricoid area, in a way is almost, I would say, anti-gravity, because if you look at the posterior pharyngeal wall posteriorly, then you have the lumen, and then the anterior portion of the hypopharynx is this post-cricoid region. And again, it's between this, separates this wall between the hypopharynx and the larynx. So when we look at the CT image here, right at the tip of my arrow, right behind the cricoid cartilage, is the post-cricoid region. And at the cricoarytenoid joint, right where my arrow is, very, very thin line here, that is the common wall between the hypopharynx and the larynx, known as the post-cricoid region. So what we've done so far is we've talked about the technique and the anatomy. Now let's talk about neoplasms. So essentially, any type of neoplasm that involves the upper air digestive tract can also involve the hypopharynx. So I've just included a few here: squamous cell carcinoma, lymphoma, minor salivary gland, sarcoma, or neurogenic. And the key thing here is that the majority of these neoplasms are going to be nonspecific. So I think any of us would be hard-pressed to separate this squamous cell carcinoma from this lymphoma. Here's a rhabdomyosarcoma, here's a leiomyosarcoma. So a lot of these pathologies are nonspecific, and the referring physician can go down and biopsy these and come up with a differential, come up with a diagnosis. So they can see what we see. So our job is not to guess the tumor, but really to determine spread patterns. Another example here to emphasize this point: this is a squamous cell carcinoma. The middle area is candida, and without the history, you may can confuse this with squamous cell carcinoma. And on the right-hand side here is tuberculosis involving the piriform sinus. So even if it's an infectious process, these can also have a nonspecific appearance. So when we talk about hypopharyngeal carcinomas, they can comprise 7% of upper air digestive tract cancers. There's more common in males than in females. It's associated with Plummer-Vinson syndrome. The average age on onset is 65 years old. it is associated with tobacco and alcohol, and only approximately 10% of squamous cell carcinomas involving the hypopharynx are HPV positive. The subsite that's most commonly involved in the hypopharynx with cancer is the piriform sinus, followed by the posterior pharyngeal wall, and then eventually the post-cricoid area. Now, this is some encouraging data from the SEER database indicating that the incidence of hypopharyngeal cancer is reducing. And this was an article published by Q et al. In the Laryngoscope in 2014 demonstrating a reduction in incidence. And this was an extension of this that was kindly calculated for me by Dr. Mustafa from Saudi Arabia, again demonstrating this decline in the incidence of hypopharyngeal carcinoma. And I would assume that this is due to diminished smoking and potentially reduced alcohol as well. So maybe a win for our public health services. So when we look at the hypopharyngeal carcinomas, as I mentioned before, the tumors tend to be very, very nonspecific. So our goal really is to identify information that's going to change how these patients are treated, and one of these has to do with the stage. So when we look at T1 to T3, T1 is less than 2, T2 is 2 to 4, and T3 is greater than 4. However, T1 is also limited to one site, and T2 is greater or equal to or greater than 2 subsites. So this is some of the information that we need to present on imaging. So as a result, we have to have a very good understanding where cancers arise in the hypopharynx. So this is an example of a hypopharyngeal carcinoma. This was a piriform sinus carcinoma involving the right piriform sinus. Notice how it's spreading along the posterior pharyngeal wall. And on the image of the right here, we can see an isolated tumor involving the mid portion of the piriform sinus. Now that's the mid portion of the piriform sinus. Remember I talked earlier that the piriform sinus has a little narrowing here that we refer to as the apex. The apex of the piriform sinus is easily seen because it's at the level of the cricoarytenoid joint. So if we're at the level of the cricoarytenoid joint, this is the level of the apex of the piriform sinus. And on the patient here on your right-hand side, this patient has a right-handed piriform sinus carcinoma involving the apex. Why is this important? Because if you have tumors that involve the apex of the piriform sinus, this increases the risk of level 6 metastases. And as a result, the surgeon, if the patient elects to be operated, must do a central neck dissection, or if the patient is treated with radiation therapy, they have to account for potential level 6 metastases. And again, we'll talk more about this later. The second subsite is the posterior pharyngeal wall. Here's a schematic illustration of a posterior pharyngeal wall carcinoma. And on the right-hand side, we can see this aggressive tumor involving the posterior pharyngeal wall on this contrast-enhanced T1 weighted image. The third subsite, as I mentioned before, is the post-cricoid region. So the post-cricoid, like I said, I consider this like anti-gravity. So the arrow right now is pointing at the posterior pharyngeal wall, and notice how this post-cricoid carcinoma is arising from this common wall between the pharynx and the larynx. So in a way, it's non-dependent. Typically it's not falling on the posterior pharyngeal wall. Rather, it's tacked to this common party wall. So it's actually anterior. So when we look at this image on the right, notice how the posterior pharyngeal wall of the pharynx is actually intact, and the involvement of the lumen is coming from superiorly from this post-cricoid carcinoma, and you can actually see some subtle erosion of the cortex of the cartilage in this post-cricoid carcinoma. So those are the 3 subsites. So in order to be effective for staging, we have to understand the subsites so we can properly determine whether or not these are T1 or T2 lesions. The next thing we have to determine is whether or not these other criteria are present. So these include things like laryngeal fixation, invasion of the cartilages, extension of the soft tissues, or involvement of the prevertebral fascia. And these are things that we can see easily on imaging. And if we see them, we need to comment on them. So here's an example of a patient that has a left-sided piriform sinus carcinoma. One thing we have to determine is whether or not this crosses midline, because if this does cross midline, then it's either going to be involving the posterior pharyngeal wall or the post-cricoid area. So if this piriform sinus carcinoma crosses midline, it involves a second subsite, and this upstages this to a T2 lesion. Similarly, as we'll see later, if the tumor crosses midline, it's also going to change the potential primary echelon nodal drainage. Piriform sinus carcinomas that are lateralized are primarily going to drain ipsilaterally, but if we say these tumors cross midline, then all of a sudden the contralateral lymph nodes become at risk. The next area that we need to see is whether or not there's involvement in this area called the thyroarytenoid notch. So if you look at the anatomy of the hypopharynx, we can see that the posterior pharyngeal wall here attaches to the posterior lateral aspect of the thyroid cartilage. This acts as a natural barrier from these tumors extending directly laterally, and as a result, it redirects these tumors anteriorly between the thyroid cartilage and the arytenoid cartilage in this space called the thyroarytenoid notch. The end result is that there's tumor extending anteriorly into this paraglottic/paralaryngeal space. And on the right-hand side, again, we can see this piriform sinus carcinoma extending through the thyroarytenoid notch into the paraglottic space. And this can result in a cause of vocal cord fixation. The next thing we want to talk about is cartilage invasion. Now, we just had a lecture on larynx where we talked a lot about cartilage invasion. So it happens in the hypopharynx too. And again, it is not uncommon because, again, of this natural barrier where the inferior constrictor muscle attaches to the thyroid cartilage. So as a result, it can redirect the tumors anteriorly or laterally. So on the left-hand side here, we can see this piriform sinus carcinoma that erodes the inner cortex and a little bit of the outer cortex. And on this MR, this T2-weighted MR, we can see edema involving the posterior lateral lamina of the thyroid cartilage. And if we see this upstages these lesions to a T4A. The next thing we want to discuss is exolaryngeal spread. So here's an example of a piriform sinus carcinoma. Now, as I mentioned before, this inferior constrictor muscle and the attachment of the thyroid cartilage acts as a natural barrier. So these tend not to extend exolaryngeal and outside into the soft tissues posteriorly, but rather they tend to extend outside of the hypopharynx through this natural defect in the thyrohyoid membrane. There's a natural defect in the thyrohyoid membrane that allows a superior laryngeal neurovascular bundle to extend into the thyrohyoid membrane. This natural defect acts as an area of egress of tumors to extend outside, and this is an example of early exolaryngeal spread of a piriform sinus carcinoma extending through this small natural defect in the thyrohyoid membrane. This is oftentimes clinically occult, but does need to be mentioned. We also can determine whether or not there's invasion of the prevertebral fascia. Now, when I trained, unfortunately, in the last century, the way this was determined, it was by the surgeon performing endoscopy and literally tugging on the posterior pharyngeal wall. If the posterior pharyngeal wall was fixed, then this would indicate involvement of the prevertebral fascia. There have been some papers that have determined that if you perform T2-weighted MR and there's edema involving the prevertebral muscles, this is indicative of invasion of the prevertebral fascia. Now, I have to admit, I haven't done very many of these to specifically look for these. I know other centers do it. I still think that surgical assessment is important, but after talking with the surgeons, they do rely on MR. So if you are going to do it, then it's important to get axial and sagittal T2-weighted images to determine whether or not there is edema involving the prevertebral muscles. And if there is, this would upstage these lesions to T4B. So we've talked about various staging. We talked about involvement of one or two of the subsites, and we also talked about some of the criteria to determine whether or not there's T4A or T4B disease. But we also have to look at the ability to determine whether or not there's submucosal extension into the esophagus. And again, this is unique. Things like cartilage invasion or multiple subsite involvement can be seen in larynx cancers, etc. But the extension into the esophagus is unique for hypopharyngeal cancers. So let's go over the normal anatomy. So this was some anatomy right at the cricoarytenoid joint, and we can see the inferior constrictor muscle and the attachment to the thyroid cartilage. And I specifically want to call your appearance to the orientation and the morphology of the hypopharynx. It has a nice smile to it, as we see in this little emoji. So there's a smile right here of the hypopharynx, and there's the little emoji sign. As we come more inferiorly and we get to the base of the cricoid cartilage, we start to see a little bit of thickening, and instead of a nice flat smile like we see in this emoji, the smile gets to become a little bit thicker. And these little areas right here where we have these little pinch points right here that are starting to attach to the cricoid cartilage, this identifies the opening into the cervical esophagus. And this transition between the hypopharynx and the opening of the cervical esophagus is referred to as the esophageal verge. Then more inferiorly, on the right-hand side, we can see the normal appearance of the cervical esophagus, and based on our emoji, that's like the surprise emoji, right? So it looks just like a circle. So if you remember a nice thin smile, that's the normal hypopharynx. Once a smile starts to get bigger, that's the esophageal verge, and eventually it turns into a big O. So how do we use this clinically? Well, this is a patient that has a left-sided piriform sinus apex carcinoma. And when we look inferiorly, we can see that the cervical esophagus looks completely normal. So we can say there's no evidence of submucosal extension into the cervical esophagus. But in this particular case, we see a large hypopharyngeal carcinoma. When we look at the cervical esophagus, we can see it's markedly enlarged. So there is involvement of the cervical esophagus. Now, this was a case just from a couple weeks ago, a very large hypopharyngeal carcinoma. This was involvement of the esophageal verge, and we can see the verge is abnormal. And when we look at the cervical esophagus, there certainly appears to be tumor involved in the cervical esophagus. Now, one can say, now hold on for a second, this looks round, so what are some other things that we can look at to ensure and increase our confidence that we're looking at tumors? Well, first of all, we want to see whether it's round, and it is round. But when we look at the normal cervical esophagus, I want to point out the stripes here. We can see an area of low attenuation here. That's probably fat. We can see muscle, and then we can see the lumen. I've always referred to these as the tiger stripes. So in the normal appearance of the cervical esophagus, you should be able to see the tiger stripes. So the things that we look for to determine whether or not there's involvement of the cervical esophagus is whether or not the roundness has changed, whether or not there is diffuse thickening of the mucosa, and then thirdly, whether or not we can still see these nice little stripes right here. And those are the things that increase my confidence. So in this particular case, we were able to say there was at least 10 millimeters of involvement involving the cervical esophagus. So what about lymph nodes? The hypopharynx certainly metastasizes to the lymph nodes, and when you have lateralized hypopharyngeal carcinomas involving the piriform sinus, they tend to metastasize ipsilaterally to levels 2 and level 3, as seen here on this PET CT. However, if you have tumors that tend to cross the midline, then all of a sudden both necks become at risk. In general, if it's far lateralized, contralateral lymph nodes are not at risk, but there is such a rich meshwork of lymphatics, and this is from Rouvier's paper nearly almost 100 years ago. You can see that if tumors cross the midline, it does involve the contralateral lymphatics, so therefore both lymphatic supplies both necks are at risk. So here's a metastases on the right, and here's a metastases on the left. And again, underscores the importance for us as radiologists to mention whether or not these tumors cross the midline, because it does put the contralateral neck at risk. The other area that we have to mention, I mentioned this earlier, was that if we have a tumor involving the apex of the piriform sinus, these tumors place the level 6 lymph nodes at risk. So again, from Rouvier's paper, we can see here's the apex of the piriform sinus, and now we can see lymphatics that are directly have primary echelon drainage to these peritracheal level 6 lymph nodes. So in this case, a piriform sinus carcinoma with a positive level 6 lymph node, and on the right-hand side, a PET MR of a hypopharyngeal carcinoma that's involving the base of the cricoid cartilage, and again, we can see a level 6 lymph node at risk. So things that we always have to look at. We always have to look at all the lymph nodes, but our vigilance has to be heightened as we specifically look at those tumors that involve the inferior portion of the hypopharynx. The other lymph node group that we may forget about are the retropharyngeal lymph nodes. So the hypopharynx and the piriform sinus is a long ways away from the skull base, but there are primary echelon lymphatics that go to the retropharyngeal lymph nodes. So anytime we look at piriform sinus carcinomas, we have to look at the skull base, and in this case, we can see a small little metastatic retropharyngeal lymph nodes. Now, I have been to several talks where people talk about, wow, this patient had a treated piriform sinus carcinoma and then developed a synchronous nasopharyngeal carcinoma. Well, that was probably due to a metastatic retropharyngeal lymph node that was not detected and was never treated. Well, we'll then move on to infections, and we're just going to spend a little bit about time on infections specifically involving the region of the hypopharynx. And you've all seen cases of retropharyngeal space abscesses. I specifically want to put this in the context of the hypopharynx. So number one, when I look at retropharyngeal abscesses, one thing I've learned is that unlike abscesses in the liver or the brain, these tend not to have an enhancing wall. They just tend to be large fluid collections that expand the retropharyngeal space that are non-enhancing in patients that are febrile and obviously very sick. So the enhancing wall, I've seen many people say, well, it can't be an abscess because it's not enhancing. Well, just realize in this area, you don't have to have enhancement. There are several causes of abscesses involving the retropharyngeal space as associated with the hypopharynx. This was a patient that had a retropharyngeal space abscess from a nasogastric tube perforation. This patient unfortunately had the classic plastic fork break off and pierce the hypopharynx, causing an abscess. This patient had a retropharyngeal space abscess from a post-cricoid carcinoma perforation, and this patient had a retropharyngeal space abscess from a posterior pharyngeal wall fistula. So these are all causes of retropharyngeal space abscesses from primarily hypopharyngeal pathology. We have to remember too that once we get back into this high rent area behind the inferior constrictor muscle, there's two specific spaces. The area here in purple is the danger space that extends from the visceral fascia to the alar fascia, and then in orange here is the danger space that extends from the alar fascia to the prevertebral fascia. So the true retropharyngeal space is in purple. This ends at approximately T2 to T6. And the orange space here, which is a danger space, extends into the mediastinum. So the bottom line is that anytime that you have an abscess involving the retropharyngeal space, we always have to include our imaging down into the mediastinum to make sure that we don't have a clinically occult mediastinitis, because this is how these tumors spread. So this was a patient that had recurrent thyroiditis. Now I put this in the infection category because there is a pathology that can cause recurrent thyroiditis. Now, once this patient was treated, we saw a small little area of air right here. And this little area of air is due to a fistula from the piriform sinus that communicates with the thyroid gland. And so we're now going to change to congenital and developmental lesions, because this leads us into the discussion of branchial cleft anomalies. So the third and the fourth branchial cleft anomalies both have fistulas that involve the apex of the piriform sinus. The third branchial cleft anomaly has its fistula that extends superiorly, and it parallels the superior laryngeal nerve and then descends in the posterior triangle of the neck. The fourth branchial cleft anomaly extends from the apex of the piriform sinus directly inferiorly. So the case that I showed before should be a fourth branchial cleft anomaly. Now, the challenge is this: these fistulas are more common than we think they are. So oftentimes we see something like this in the child and we call it a lymphatic malformation. Well, I've had several cases where this has been resected and it's turned out to be a third branchial cleft anomaly. Similarly, these little fistulas that extend from the piriform sinus into the thyroid gland, these are the fourth branchial cleft anomalies. And it's important that we, the radiologists, understand the difference. Because when the pathologist looks at this, all they see is that they see pathology consistent with a branchial cleft anomaly. That's all they can say. When the surgeons look down, they see the fistula. So they think, well, yeah, there's probably a branchial cleft anomaly here because there's a fistula involving the piriform sinus. But it's really us as the radiology to map the specific location. So if we see something in this location, in the posterior triangle, and the pathology comes back as we see here, this is a third, we can say that. And the case inferiorly, we can see this air extending into the superior aspect of the thyroid gland. We can then say definitively that this is a fourth branchial cleft anomaly. So I would argue that it's really up to us as a radiologist to make the specific diagnosis as to the specific embryologic cause of the branchial cleft anomaly. And the last area that I'll talk about is a developmental abnormality, and this is the classic Zenker's diverticulum. Zenker's diverticulum is caused by uncoordinated hypopharyngeal contraction against a dysfunctional cricopharyngeus muscle. So typically when we swallow, we have these swallowing waves that involve the inferior constrictor muscle that are continuous with opening and closing of the cricopharyngeus muscle. If there is uncoordinated contraction, the cricopharyngeus muscle does not relax but continues to be constricted. there is a small little defect here between the inferior pharyngeal constrictor muscle and the cricopharyngeal muscle. This is called Killian's dehiscence. So you can see is that the inferior constrictor muscle is pushing the food down and the cricopharyngeal muscle does not relax. You can end up developing a pulsation diverticulum through this natural defect. And this is what's referred to as Killian's dehiscence. So this is an early pulsion diverticulum, and this is the more advanced pulsion diverticulum. So how do they look on imaging? This is the days when I used to do barium swallows. This was a cricopharyngeal muscle that did not relax. And you can see superiorly to it, we can see the Zenker's diverticulum extending posteriorly along the cricopharyngeal muscle. This was a Zenker's diverticulum that was oral contrast, and we can see contrast in the Zenker's diverticulum. And on axial images, we can see oral contrast within this diverticulum. Now, you can look at this and say, wow, it sure as heck looks like an abscess, but realize you have to put everything in the clinical context. And in this particular case, the patient had no fever. They had signs of difficulty swallowing and reflux. So as a result, we can make the diagnosis and feel very comfortable that we're dealing with the Zenker's diverticulum. So in summary, over the last 30 minutes, we've talked about technique, anatomy, neoplasms, infections, and congenital and development anomalies involving the hypopharynx. Thank you very much for your attention.